Okay.
All right,
Thanks for doing this.
yeah, no problem. I'm bored, so it works out. It's kind of a nice break. You guys can see my slides?
Yeah.
All right, these are pretty basic. I haven't had a lot of time to really put them together, but I've kind of pulled from a couple other slides I've had. Let me see if I can slideshow this now. All right, so this is pretty basic talk. Like each of these can be like several hours long, but we're gonna just try to like do a fellows level stuff. Like this is similar to what I think you should get at like a, if you were to go to like an NKF talk on IgA, they would give like a big overview of it. So if there are any points that I feel like I'm glossing over, just like ask me to expand on them. We're going to just go over briefly clinical characteristics. We're going to focus on pathology. We'll talk a little bit about pathophys, a little bit about treatment, and then we're going to end with some secondary IgA nephropathy cases, just so you have an idea of what those are. So this is the case that I actually had put in my biopsy slides a few days ago. So a relatively young, healthy person with gross hematuria, 2 days prior developed cough, runny nose, symptoms consistent with a URI, has 1 plus protein, 3 plus blood, pretty minimal proteinuria, certainly subnephrotic, 0.6 grams per gram, and preserved kidney function. So the clues here are that they have gross hematuria, because that is actually one of the manifestations of IgA nephropathy. Not always, but certainly one of the ones that you should think about. The association, how it occurred with a respiratory infection. So sometimes it's called synpharyngitic. It's not like post-infectious where you would get the infection a few weeks before. This occurs at the same time as the infection. You have blood, minimal protein, and preserved kidney function. So at the top of your list, if you heard this presentation, you should be thinking of IgA. So IgA originally was called Berger's disease because it's named after this guy, Jean Berger, who was a French physician. And IgA was something that came about because immunofluorescence came about. So you'll see the definition of it is that you must have IgA dominant staining on immunofluorescence. So IgA nephropathy didn't really exist until immunofluorescence existed in the mid 60s or so, and it was first described by this fellow, which is why it was named Berger's disease for so long. It's oftentimes quoted as the most common primary glomerulonephritis in the world, and it is one of those that actually has a very unique racial demographic. So when you think about a lot of diseases like FSGS, lupus, things like that, they're much more common in African Americans compared to non-African Americans. And IgA nephropathy is probably one of the only diseases that's kind of the inverse of that. It's extremely uncommon in Black population. So if you look at all of the major cohorts looking at all IgA patients, almost universally about only 5% of them are made up by African Americans, whereas the rest are Caucasian, Asian, Hispanic. So these are common diseases, and it's one of those where if you hear like that a patient is African American, IgA nephropathy automatically should kind of drop down a little bit on your list, just because it's not as common. Not that it's impossible, but it's just not as common. So the clinical initial presentations oftentimes are macroscopic hematuria. The patient will notice that they have gross hematuria. Oftentimes it's found incidentally when you present for example, like routine physical screenings, or if you were to get life insurance screenings or military screenings, things like that, and they would dip your urine and they'd notice microscopic hematuria. It can present as nephrotic syndrome. It can present as like a rapidly progressive GN, but those are uncommon. It's one of those diseases that's incredibly variable, both in terms of clinical presentation and also in terms of pathology. We're going to go to the pathology later. But usually it's either microscopic or macroscopic hematuria. So it usually falls into kind of like a nephritic-like picture. It's rarely nephrotic. It's rarely an RPGN. And I already mentioned this before. It's a synpharyngitic nephritis, which means it occurs at the time of an infection. So I just had a patient, for example, who had IgA, who had around Christmas time a viral infection and then just started peeing blood. And so IgA oftentimes flares along with the viral or even bacterial infection. The proteinuria is present because this is a glomerular disease, so you still have proteinuria, but again, not commonly nephrotic range. Usually it's 1 gram or less. And we'll talk about why that 1 gram is important prognostically, because patients who have less than a gram tend to do pretty well. Patients who have more than a gram tend to not do as well and may need more aggressive treatment. If at any point you want me to slow down or expand on things, just chime in. There's only a couple of us, so we can just talk. So the pathophysiology, you don't have to know all that much about it, but you have abnormal IgAs that are circulating in your body, and you get glycosylation of the hinge region of IgA, which ends up causing the disease. Now, there's a lot of talk about multiple hits causing this. Sometimes it's a genetic abnormality on top of some kind of environmental insult that causes this. But here's like the general idea. You have some abnormal glycosylated IgA, and as a result of that, you produce anti-IgA antibodies, which form circulating complexes, which would then deposit within the kidney and cause the local immune complex activation, complement activation, and injury within the kidney. And this is a process that occurs over a long time. So here's basically the same slide with words, but this is going on over 20 years. So for example, our patient in that vignette, we're probably catching them pretty early on, hopefully at a point where it is not yet progressing to long-term renal outcomes, because this is a disease that kind of smolders and takes a long time usually to progress. It can present, like I said, as an RPGN, but that's pretty unusual. So this is something that patients will live with for a very long period of time and may or may not become a problem for them in their life. So here are the questions I think are going to frame kind of the rest of our talk. Let's take our first vignette, which is not uncommon. And let's say you even biopsy them and you have a biopsy that shows IgA. And the patient says, okay, what does that mean for me? Like, I'm 35. Does that mean I'm going to need a transplant or dialysis? How do those patients do in the long term? Is it progressive? What clinical characteristics would say that this patient is going to do well or poorly? And then what on the pathology is going to say they're going to do well or poorly? So let me actually ask you guys, we got about 4 people in the chat. What would you say to this patient? They said, how am I going to do long term? Is this something that I'm going to have to deal with like forever? Am I going to end up on dialysis? What would your response to that patient be? All right, let me look at the chat here. Sana says slow progression. Slow meaning what? Like years, decades? What do you think? And then, okay, years, okay. And then what clinical characteristics would tell you if a patient's going to do well or poorly? Okay, so Anish, proteinuria more than a gram. That's a good one. Okay, so this patient had pretty low level proteinuria, so that's good. Any other clinical characteristics? Okay, Gonzalo says intermittent flares. So that's actually pretty interesting. Patients who actually have flares when they have like an upper respiratory tract infection and have that gross hematuria, interestingly, they tend to do better than those who don't have gross hematuria. I don't really know why, but that's certainly something that comes out when you look at the long-term prognosis. Okay, the other big ones obvious one would be the creatinine, right? So if you're catching it, so let me go back a little bit. So if you're catching, let's say you're catching IgA already way down here, and then you've had it for 10 years, and the creatinine is already 1.5 or 2, okay, that's a bad prognosis. And the other big one, clinical prognosis, is blood pressure. Okay, so patients who are hypertensive, who have more than a gram of proteinuria, who already have impaired GFR, those are the people who do poorly. And then how about histologic characteristics? What are we going to look at on the kidney biopsy to tell if a patient is going to do well or poorly? Can you think of anything? Okay, IFTA, so interstitial fibrosis and tubular atrophy, that's a big one. That's probably the most important one. Crescents, Gonzalo says crescents, that's a big one. Crescents, great. So there's a whole bunch of actually pathologic histologic criteria, and we're going to look at all those. All right. So when you look at patients, and you're gonna try to prognosticate them. You're gonna look at those risk factors clinically. So how long has this been going on? So we may not know that, right? We're biopsying them at one time, and actually the pathology helps us there. How bad is their proteinuria? Usually the cutoff is around 1 gram for good versus bad, blood pressure, and the level of GFR. So patients who have risk factors, let's say they have proteinuria of more than 1 gram a day or hypertension, even those patients are not guaranteed to end up on dialysis. If you look at those patients who have those risk factors and you look at them over 20 years, only about 30% will end up on dialysis. Okay, so it's a real slow progressive disease. And there are hopefully some things that we can use to alter that course over 20 years. But for example, our patient who's 35, healthy, normal blood pressure will assume, low level proteinuria, a creatinine of 0.6, I would really assure them that at this point, they're really, really low risk of having to end up on dialysis. Of course, they need to be watched over time, and they need to see a nephrologist, and they need to have their protein and their blood pressure checked. But unless any of those kind of flare up, that patient is probably going to do really, really well in the long term. Okay. So here's kind of looking at that proteinuria cutoff. If you look at patients who have proteinuria less than 1 gram, okay? So our patient, for example, and you look at them over 20 years, it's a really long time, only 2% end up on dialysis. Whereas if you take those patients who have more than 1 gram, like I said, about 1/3 of them will end up on dialysis. So that proteinuria is really important to know up front. And then the histologic findings we're going to talk about. And so there's been a lot of talk about, can we use the biopsy to help us prognosticate which patients are going to do well, which patients are not going to do well. And so the histologic findings are really variable. I think the 2 diseases that can probably look like everything are lupus and IgA nephropathy. But I would say the most common findings of IgA are these, and there's actually a scoring system designed for them. So mesangial hypercellularity, segmental scars, endocapillary proliferation, crescents. There can be a lot more. There can be MPGN patterns, there can be TMA patterns, there can be all sorts of weird stuff. But these are kind of like the most commonly found things. And then don't forget that you must have the IgA dominant staining on immunofluorescence to make the diagnosis of IgA nephropathy. So if you don't have IF, you cannot make the diagnosis of IgA nephropathy. Okay, make sure I can view the chat and we're still good. Okay. Let's see. Pull up the chat again. What's the difference between mesangial hypercellularity and endocapillary proliferation? All right. So in words, they both mean too many cells, but it's where the cells are. So when you say mesangial hypercellularity, you have too many cells within the mesangial matrix, in the area that's holding those capillary loops together. Endocapillary proliferation is too many cells within the capillary loop, that it's actually plugging up the capillary loop, and the loops are now closed because they're filled with stuff. So that's endocapillary proliferation. Mesangial hypercellularity is just too many cells within the mesangium, but then the capillary loops themselves are open. Okay. Okay, Oxford classification. So this is something that came about when I was a fellow, I want to say 2009 or so. So it's been around for a while now. It's called the MEST-C criteria. So they look at these 5 things: M, mesangial hypercellularity; E, endocapillary proliferation; S, segmental scars; T, tubular interstitial fibrosis; and C, crescents. And they would grade them 0, 1, 2. You don't have to know the grading per se, but you have to know that the presence or absence of these are kind of what will tell you how well a patient will do based on the pathology And then those clinical characteristics, blood pressure, GFR, and so forth, will kind of tell you how they're going to do clinically. So you kind of use both of those in conjunction to try to make a prognosis for the patient because it's such a variable process. Okay, so let's look at a patient. So you have the IgA dominant staining. Okay, so that's how you make the diagnosis. So you must have IgA dominant. It can be positive for IgG2, but it must be dominant with IgA, which means that the brightness of the IgA is the brightest of all of the immunoglobulin stains. Okay. Or co-dominant, so at least as bright as the bright stain. Okay, so the deposits are usually in the mesangial area, but they can actually be anywhere in the glomerulus. And I already mentioned that. All right, so let's go through this. We have, let's see. Actually, I won't have anyone turn your mic on, but go ahead and just look at this biopsy and just type into the chat, what stain is this and how does it look to you? Okay, so trichrome is correct. And it looks pretty good. So I heard minimal scarring looks okay. So you know it's a good sample. You got plenty of glomeruli here. And when you look at the trichrome, you're going to try to look to see if the tubules are back to back, how much blue space is in the interstitium. And when you look at like all these tubules here, they're all completely packed in nicely. There's not much space in the interstitium. Might be a little bit right here, but this is on the edge. Might be a little bit here, but this looks pretty good. All right, so this is actually how they would do the T-score of the MESC. They would say, okay, so there's about 10% tubular interstitial fibrosis, so this would be a T0 or whatever it would be. So the T1 is more than 25%, the T2 is more than 50%. But yeah, this looks pretty good. All right, let's go to the next one. So what stain is this, first of all? So this is an H&E. Yep, low power H&E. And yeah, Sana says maybe hypercellularity. Gonzalo's saying the same. Yeah, you can kind of tell that maybe there's something going on there. But yeah, I'll give you a higher power view. So here's your higher power view. And so this shows hypercellularity, right? Okay, so hopefully you can appreciate that. Like here, 1, 2, 3, 4, 5, 6 cells kind of bunched up. Here, 1, 2, 3, 4, 5. You know, so there's definite hypercellularity. So kind of back to Sana's question. So this is mesangial hypercellularity because you're looking in the mesangium. Again, that's the matrix that holds it all together. That's where you see hypercellularity. When you look out into the capillary loops, this looks normal. Okay, you have an occasional like endothelial cell here, but if you had endocapillary proliferation, you'd have cells plugging all of this up here, and those capillary loops would be closed. But when you look out to the periphery here, the loops are open, and you don't see a bunch of cells in them, so there's no endocapillary proliferation here. So if we were being a pathologist here, we would say this is a T0 because the tubular interstitial fibrosis was minimal. This would be an M1 because there's mesangial hypercellularity. It'd be an E0 because there's no endocapillary proliferation. And then we look at segmental scars. I don't see scars here, so S0. We look for crescents, it'd be C0. So whenever you get a biopsy back on a patient with IgA nephropathy, you're gonna get like the normal report, but then Joe will also score it at the bottom with M, E, S, T, and C. And you can kind of look at that and see, you know, what are the IgA pathologic prognostic criteria based on the Oxford classification. Okay, here's a PAS. Okay, hopefully you can tell the difference between the last one and which was H&E. So here you have the basement membrane staining really nicely, the tubular brush border staining, Bowman's capsule staining. And again, you see hypercellularity, right? So here's a mesangial area. 1, 2, 3, 4, 5, 6, 7, 8, 9 cells in the mesangial area, okay? And again, capillary loops, these look fine. These look fine. There's not cells plugging them all up. There are, your endothelial cells, which are normal, but there's no endocapillary proliferation here. I'll show you a picture later on. I have another case with endocapillary proliferation. All right, what do we have here? I think this is a different biopsy. I just pulled it out to show you the example. So what are we looking at here? If this was an IgA nephropathy patient, what are we looking at? Okay, so it's a PAS stain, excellent. There is mesangial expansion. Okay, so Gonzalez's scar, question mark, or fibrinoid necrosis? Yeah, it's hard to tell. Fibrinoid necrosis looks better on an H&E because the normal pink of the mesangium contrasts really nicely from the bright red of the fibrinoid necrosis in the fibrin. This is a segmental scar. Okay, so you have here an area out here that's scarring. This is what they would call a synechia, which is like adherent to Bowman's capsule. So this would be a segmental scar. So if you saw this, it would not be unusual in IgA nephropathy. Don't forget that segmental scars are not specific for any disease, right? So not even FSGS is specific. Segmental scars are not even specific for FSGS. You can get segmental scars in a lot of diseases. So this can be seen in IgA, and this would be something that would be scored as well. I don't even know what the point of this slide was. We'll just skip it. All right, so then you have IgA dominant staining. All right, here is EM on a patient. So I'm not going to ask you to read the whole thing, but I'll ask you, where do you see deposits? Do you see them in the mesangial space? Do you see them in the subendothelial space? Subepithelial space? Yeah, mesangium, great. Okay, so you see them here in the mesangium. All right, and that's kind of classic for IgA, but also not specific. You can have deposits really anywhere, but in the mesangium is what you'd expect. Here is the capillary loops, okay, and you don't see any deposits. So that would be kind of a classic kind of mesangial IgA. So we're going to get into some more path a little bit later on. There's some secondary cases, a very challenging one, which maybe we'll have you kind of look at together. But then how do you treat these patients? Okay, so you have to really tailor your treatment for the patient, right? So not all IgA patients are treated the same. Like when you have minimal change disease, pretty much all patients are treated the same, steroids, right? When you have a diagnosis of IgA, you really have to think, what's this patient's risk? What is going to cause them to progress? What are the treatment options that I can do for that? Okay, so there are some universal things, like you would give an ACE inhibitor or an ARB if they had proteinuria, especially if they were greater than 1 gram. It's standard of care for patients with more than 1 gram of proteinuria to get an ACE inhibitor or an ARB. It would not be wrong, for example, in the vignette that I gave you earlier, a 35-year-old with a creatinine of 0.8 and proteinuria of 0.6, I personally would still put that patient on an ACE inhibitor, okay, to try to reduce that proteinuria more. There's been a lot of talk over probably about 3 decades of using fish oil because of its anti-inflammatory properties. The benefit has definitely not really been established very well. Some people will still use it. There's even prescription fish oil that you can use for IgA nephropathy. There's certainly no harm to it, but there's also unclear benefit. You may or may not see this out in practice. I personally don't start patients on fish oil with IgA, but I also don't stop it if they've already been put on it by someone else. They looked at doing tonsillectomy in actually some patients because the majority of IgA that is produced is made in your tonsils and also within the Peyer's patches of your gut. So if you remove tonsils and suppress IgA production, could you potentially make IgA nephropathy better? Not well established, although I would say probably about 15 years ago, this was something that people were doing or considering. And then the big question is, do you do immunosuppression? So that's what we're going to kind of lean towards. So there's two big trials looking at steroids. One was called Stop IgA Nephropathy. It was published in New England Journal in 2015. They basically randomized IgA patients to supportive care versus steroids versus Cytoxan and steroids. And for those Cytoxan and steroids, they were if they had a lower EGFR. And what they found was that actually proteinuria did improve in all treatment groups, but there was no change in EGFR, and there was significantly more adverse effects, mostly infections, when the immunosuppression was given. There was another trial called Testing, which they did just a few years ago. I have a visual abstract for that here. All right, so they took patients who had IgA nephropathy, pretty wide range of GFR. All of them had more than a gram of proteinuria. All of them got a run-in of the standard of care, which was ACE inhibitors or ARBs. Some patients just with that had reduction in the proteinuria and they were excluded. For patients who still had more than a gram a day, remember my curve, those gram a day patients in the long term, about a third of them end up on dialysis. They randomized those patients to steroids versus placebo. And what you can see here is that there was actually a pretty steep increase in the serious adverse events without a change in the GFR. So, this is not a 20-year trial, right? So when you look at IgA, you're looking at dialysis, you're looking at 20 years. This is a 2-year trial. And so they used a surrogate marker of 40% drop in GFR, and end-stage kidney disease or death. And so there's really no difference between those two groups. But if you look here, the patients who were put on steroids, a lot more serious adverse events. Most of them were infections with a number needed to harm of 10. And what's interesting is the majority of the infections in this trial were PCP pneumonia, which is a pretty bad one to get. There's actually another trial underway right now called Testing 2, where they're basically doing the same thing, but they are giving PCP prophylaxis to the patients who are on the steroids. So this is kind of jury's still out there. You can consider using steroids for these patients, but you have to be careful. And then the question becomes like, how long do you use steroids for? I mean, it's hard to be on steroids for this long. So general rule of thumb is if you have a pretty mild disease, you're not going to be treating aggressively. You're going to use ACE inhibitor, you may use or see fish oil, and then you're going to try to tailor whether or not this patient needs immunosuppression. So for our patient in the vignette, they had pretty good IgA nephropathy. They had good prognostic factors based on their clinical characteristics. And if their biopsy didn't show crescents or anything like that, I would just monitor them with an ACE inhibitor or an ARB. If they had more than a gram of proteinuria, you're definitely going to use the ACE inhibitor or the ARB. You may or may not add a little bit of steroid. And then there are those rare patients, the bad IgA nephropathy. Remember, this is less than 5%, but it can present like nephrotic syndrome. It can present like RPGN. And for those, the patients need usually a steroid plus a cytotoxic agent. Here is kind of like a table kind of summing up kind of how you should approach it. So all patients should have blood pressure control using ACE inhibitor ARB, plus or minus the fish oil, tonsillectomy if recurrent tonsillitis. I've never actually referred a patient for tonsillectomy. For mild disease, you're probably going to do nothing. Okay, if they have proteinuria that's a little bit higher, then that's when you're going to be thinking about steroids. Now, this next one is interesting. Point of no return. We've heard this a lot in IgA nephropathy. So the point of no return basically is, let's say you biopsy a patient who has a creatinine of 2.5, and they have some hematuria and don't have a good explanation for this. I have a patient like this. So I saw a patient who actually had she was like 45 or so. She had a creatinine of 3.8. And it had actually been gradually going up for years by her primary care doctor, and no one ever did anything about it. When I biopsied her, she had IgA nephropathy, but she had pretty severe tubular interstitial fibrosis. So about 75% of her kidney was just completely fibrotic and scarred. I think like 20 out of 25 glomeruli were completely globally sclerosed. So even though that patient has low GFR, that's not someone that I want to give high doses of immunosuppression for, because the likelihood of turning that around and getting her back to healthy kidney function is low. So that's what we call the point of no return. So if you feel patients have passed the point of no return based on their creatinine and based on how much fibrosis there is on their kidney, you're not going to actually give them immunosuppression. All you can do is really get them ready for transplant. And that's what I did for my patient. She got a preemptive transplant. Okay. On the other hand, if you had a patient who had a creatinine of 2.5 and it was going up pretty quickly over the last few weeks or months, and they had crescents, that's a patient that you're going to have to give steroids and cytotoxic agents. So you can see like there's this huge variety in treatment options, and it totally depends on kind of like what the patient has and so forth. So there's a lot going on. All right, secondary IgA. Let me make sure there's no questions in the chat. Maybe pause there, maybe make sure there's no questions from the chat. Okay. All right. Okay, so there are some secondary IgA. They can be associated with cirrhosis. Okay, so usually patients with cirrhosis are excluded from IgA trials because immunoglobulins in general are cleared by the liver. And so if your liver is dead or cirrhotic, you're going to have accumulation of immunoglobulins, and some of those can deposit. So you can have IgA nephropathy and just cirrhosis, but we don't consider that pathologic per se. It can be associated with some other GI diseases. So celiac and inflammatory bowel disease can also have IgA. You can also see it with HSP, or henoch-Schönlein purpura, where you have IgA deposits in the kidney and this palpable purpura, which is usually on the thighs and the butt of patients. And actually, if you were to do skin biopsies of these patients and do immunofluorescence on their skin, they would also stain for IgA. All right. Here's another case vignette. Some of you may or may not know this. Like we've had a couple cases like this in the hospital. So I want to kind of read it out. So here you have a 65-year-old female. She's got diabetes. She's got hypertension, coronary disease, peripheral vascular disease. She is draining wound. She has a draining wound from the site of a former fempop bypass, and pus is coming out, which grows MRSA. So she started on Vanc. On hospital day 2, her blood cultures also are growing MRSA. She gets an echo, which reveals a large mobile vegetation on the mitral valve. So she has MRSA endocarditis. So they add gentamicin and rifampin. Her creatinine 6 months ago was normal, and on admission, it's 1.5, and it slowly worsens in the hospital. So here's her serologic workup. You have normal complement levels. She has a cryo, but it's only 1%, ANCA negative. Her urine shows 3+ protein, large blood, 10 WBCs, 80 RBCs, 2 granular Cas, and a urine protein to creatinine ratio of around 2 grams per gram. Okay, so I'll back up first. This is a case from my fellowship, and her creatinine went up and up. So it went from 1.5 to 2 to 2.5. We biopsied her when her creatinine was like close to 4. And here's what we saw. So these are actually cases from my fellowship. Let's have you guys read through these. So what stain and what do we see here? Okay, definitely an H&E Gonzalo, so that's correct. Okay. So a lot of stuff going on. Right. Yeah. Okay. So initially, Gonzalo had said mesangial hypercellularity, which there might be some, but the location of the cells here is a little different than the last one. Notice here how the capillary loops are closed. Right here, look at the cells. They're within the capillary loop. So this is endocapillary proliferation. Here's your mesangium. Doesn't actually look supercellular. Hard to tell where mesangium ends and where capillary loop begins. But you're looking in this area, which is clearly mesangium, and there's not a lot of cells. So they're kind of distributed out in the periphery. So you have, look in this glomerulus. This would be a capillary loop, and now it's just filled with cells. So this is endocapillary proliferation, and yes, it's an H&E. So it says casts within tubules, interstitial proliferation. Yeah, so there's some stuff going on here. We'll kind of get back to that later. This I'm not sure if these are casts. I think this is just some junk. This is just like ATNE junk. So I'm not sure that I see tubular casts anywhere. There is some inflammation here. All right, so, but this is a good picture of endocapillary proliferation. Okay, it's different than the last one we had. Here is another view of it. All right, so some of the capillary loops are open, right? So these look good. And then some of them are not. This one's definitely not. This one, you can see a lot of cells in it. So some of the loops are open, some of them are not. You look at the mesangium, like doesn't look as hypercellular as the last one, maybe in this area a little bit, but we don't have tons of cells in this area. Most of them are out in the periphery within the capillary loops. All right, what's this? This is a hard case, so don't feel bad if you don't know it. This is a challenging case. So one of the ways I approach this is, okay, so yeah, definitely endocapillary proliferation, as mentioned. So one of the ways I approach a biopsy when I don't know what I'm looking at per se is I just start describing what I see, and you try to be as objective as possible. So you can just say, even if you're ever stuck up there in biopsy conference and you're like, and someone, and Dan Coyne's like, hey, what is this? And you have no idea what it is. You can say, well, we're looking at a high power view of a glomerulus. It's an H&E stain. It doesn't look normal. And then you try to describe why it doesn't look normal. So there's an area here at like 2 o'clock, which doesn't look normal. But before you even get there, look at the rest of the glomerulus. Are the capillary loops open or closed? They're pretty closed. I mean, there's proliferation here, proliferation here, proliferation here. So the capillary loops are closed. There's endocapillary proliferation. And then at 2 o'clock, there's an area of brighter pink red compared to the remainder of the glomerulus. So this is an area of fibrinoid necrosis. Okay, so this is fibrin. And it's different than a scar, because if this was a segmental scar, it would be collagen and it would all be the same color. It would all just be pink, and usually it wouldn't have a bunch of cells within it. There's a lot of cells here. There's bright pink. So this is a fibrinoid necrosis with endocapillary proliferation. Okay. This is just showing some tubular injury. I don't think we have to get into that per se. All right. So here is immunofluorescence. Here's IgG, IgM, and here's IgA. Okay. And you can see again, the brightness is out in the capillary loops. Okay. You can even see capillary loops and how bright they are compared to mesangium, which is this stuff, not as bright. Okay. And that fits with kind of what we saw on the H&E. So there was also C3 staining in this case, despite the fact that the complement levels were normal. And you can actually do fibrin staining on IF2. So that area of fibrinoid necrosis that we saw is, and here's an area of fibrinoid necrosis and what would it look like if you did a fibrin IF stain. You don't have to do this, but you can if you're not sure what you're looking at. All right, this is complicated. So I don't envision that you would know exactly what you're looking at, but because it's so abnormal. But first, try to differentiate where we are. So what am I running my mouse over here? What is this? Right, basement membrane, and this is the capillary loop. Okay, so this is the basement membrane capillary loop. So this then looks like which space, blood or urine? Excellent. Urinary space. So these must be what? Yes, the foot processes of the podocyte. So the podocytes themselves look terrible, right? There's no foot processes that we can see. Here's our urinary space. Here's our capillary loop. So by default, this must be our blood space. But what is so abnormal about this? Normally, this is a big white area, right? So what are we seeing here instead of that big white area? Yeah, so it's closed, right? So Sana says this is the closed space with expansion and Anisha cells, right? So this is what endocapillary proliferation looks like on electron microscopy. You have nuclei of cells here, and this whole area is closed, right? So normally this would be big and white space. So this is what endocapillary proliferation looks like on EM. So this is the same as this. Okay, we're zooming in on a capillary loop, and we're just not seeing that space. Now, if we had zoomed in on a different capillary loop, like this one's open, if we had zoomed in there, that would be normal. But what we are seeing is this area right here, which just filled with cells. All right, let's look for deposits. Where do you see the deposits here? Try and figure out where they are. Lovely. Subendothelial, maybe mesangial too. Correct. So the big one here is subendothelial, right? You can see here a capillary loop, urine space, podocyte, cells filling up that capillary loop space. And here, look at that, massive subendothelial deposits there. Okay, more here. Maybe some in the mesangium as well. Definitely actually some in the mesangium as well. But you have big subendothelial deposits. Okay, so we have the diagnosis of IgA in this patient who has MRSA bacteremia and MRSA endocarditis. So is there an association, and what do we call this entity? Excellent. So IgA dominant infection associated GN, infection related GN, IgA dominant. Right. So IgA dominant infection associated GN. So this is kind of like a hybrid between IgA nephropathy and post-infectious GN. Oh, why was cryo checked? Well, cryos can sometimes actually be elevated in patients who have post-infectious GN because the antigen antibody complexes, as they precipitate, can oftentimes cause a cryoglobulinemia as well. So that's why it was checked in this patient. So it's a hybrid between IgA and post-infectious. So when you think about post-infectious GN, we usually think about strep. We usually think of it as being low C3, complement mediated. But then we as adult nephrologists don't really see very much post-infectious GN from strep, but we actually do see infection-associated GN from staph usually, sometimes gram-negative bacteria. And these patients don't do nearly as well as children who have classic post-strep GN. And oftentimes, the staining for this is IgA dominant. So it's kind of like a subset of IgA nephropathy as well. It affects older adults. Diabetes is a significant risk factor. And so it has this mixed picture. You can sometimes have low complement levels. You definitely will still have IgA dominant staining on IF, but oftentimes there's other immunoglobulin staining like IgG and C3. And then your EM can show deposits anywhere. So we saw these massive subendothelial deposits, but you can also see the big humps, which are subepithelial deposits of post-infectious GN as well. Actually, I think that's it. That's all the slides I had time to put together. You guys, do you have any questions? You guys can turn your mics back on and just ask questions if you have any. Should we then biopsy more suspected infection-related GN cases? So I don't know. It's tough because we see a lot of endocarditis, right? So I think you and I just had this patient that we thought maybe had it. But you have to think like, what are you going to do about it, right? So those patients oftentimes have such severe infections that you don't want to give them immunosuppression. And the treatment is still to treat the underlying infection. But oftentimes those patients just don't do as well because it's hard to treat endocarditis, right? But usually you're not going to be slamming those patients with steroids and things like that. Anish, IgA and cirrhosis so usually IgA in the presence of liver disease is just kind of like an incidental finding. So I think that's something that is born out of autopsy cases, that because they have decreased circulating or decreased clearance of circulating IgA, some of it deposits, but I don't believe that it causes kidney disease per se. You're welcome, Blessing. Any other questions? I'll send you these slides, or I'll put it up, and I'm going to figure out how to post this video afterwards. And yeah, if you guys have any other questions, just shoot me an email or something. We can talk more. And I have another noon conference in a couple of weeks. We can either do the I have some slides where I was going to talk about myeloma kidney disease, although I think we had a grand rounds on it recently. If you wanted to, instead of doing that, we could just do, we can have the second year's read biopsies. They're a little bit more challenging. Do you guys want to do that instead? I think Anish is the only second year here, so. All right, we'll talk about it. We'll communicate via email and we'll figure it out. Yeah, biopsies, Gonzalo votes for those. Yeah, I'll put together some more cases and then maybe we can have the second years do them and then the first years can learn from that. All right. Well, it's good seeing